In the mid-19th century, as steamships stitched distant ports together and railways accelerated the movement of people and goods, a silent danger traveled along the same routes that symbolized progress. What began in the highlands of southwestern China would soon follow trade paths across Asia, cross oceans to distant continents, and reshape how the world understood disease. Within a few decades, a single bacterial infection would affect cities from Hong Kong to San Francisco, from Bombay to Cape Town, leaving governments, scientists, and entire populations struggling to understand how a disease could move so swiftly through a newly connected world. The origins of what would later be known as the Third Plague pandemic can be traced to the province of Yunnan in southwestern China during the early 19th century. Yunnan was a region of rugged mountains, mineral wealth, and expanding trade networks. During this period, mining activity increased significantly as workers migrated into the area. Population movements, crowded settlements, and the transport of goods created environmental conditions that allowed disease to circulate more easily among both humans and animals. Plague was not a new disease. Historical records describe earlier outbreaks stretching back centuries, including the devastating pandemics that swept through Europe and parts of Asia during the Middle Ages. However, by the 19th century, many societies had little direct experience with the disease. Medical knowledge remained limited, and the mechanisms of transmission were not yet fully understood. In Yunnan, reports of unusual and deadly illness began to appear during the early 1800s. The disease spread gradually through rural communities before reaching larger population centers. Political instability and regional conflicts during this period made consistent record-keeping difficult, but accounts from local officials described sudden illness, swollen lymph nodes, fever, and high mortality rates. As the decades passed, the disease continued to circulate within the region. By the 1850s, increasing trade routes linked Yunnan more closely with the coastal provinces of southern China. Caravans moved goods such as tea, metals, and textiles along established routes toward major ports. With them traveled rats, fleas, and infected animals that unknowingly carried the bacterium responsible for plague, now known as Yersinia pestis. Though the bacterium itself would not be identified until later, the disease was already beginning its wider journey. The turning point came in the 1890s when the outbreak reached the bustling port city of Hong Kong. At that time, Hong Kong had become a major hub of international commerce under British colonial administration. Ships arrived daily from across Asia and departed for destinations throughout the world. The city's dense neighborhoods, crowded housing, and active maritime trade created conditions in which disease could spread rapidly. In 1894, a major outbreak of plague struck Hong Kong. Hospitals quickly filled with patients suffering from severe fever and painful swellings in the lymph nodes, particularly in the groin and underarms. Mortality rates were extremely high, and fear spread through the population as authorities attempted to respond to a disease whose transmission remained poorly understood. The outbreak in Hong Kong also marked a crucial moment in the history of medical science. Two researchers working independently arrived in the city to investigate the epidemic: Alexander Yersin, a Swiss-French bacteriologist associated with the Pasteur Institute, and Shibasaburo Kitasato, a Japanese physician trained in bacteriology. Both scientists conducted urgent investigations in difficult conditions as the epidemic unfolded around them. Within weeks, Yersin succeeded in isolating the bacterium responsible for the disease from infected tissue. His work confirmed that plague was caused by a specific microorganism rather than by vague environmental influences, a concept that had previously dominated many medical theories. The bacterium he identified would later be named Yersinia pestis in his honor. This discovery became a major milestone in the emerging field of bacteriology and laid the groundwork for future research into plague transmission and treatment. Even as scientists began to understand the biological cause of the disease, the epidemic was already spreading beyond Hong Kong. International shipping networks connected the port to cities across the globe. Rats living aboard cargo ships traveled between ports, carrying fleas that could transmit the bacterium to new populations. Through these maritime pathways, plague began appearing in other major port cities. Bombay, now known as Mumbai, experienced one of the most severe outbreaks during the late 1890s. As a major center of trade in British India, Bombay had a large and rapidly growing population. When plague cases began appearing in the city in 1896, local authorities faced enormous challenges. Hospitals struggled to keep up with the number of patients, and many residents fled the city in fear of the disease and the strict quarantine measures imposed by colonial officials. Public health interventions during this period were often controversial. Authorities implemented house inspections, isolation of suspected cases, and restrictions on movement. In some neighborhoods, entire families were removed from their homes and placed in quarantine facilities. These measures were intended to contain the disease, but they also caused significant social tension. Many residents viewed them as intrusive or discriminatory, especially when enforcement appeared uneven. Despite these difficulties, the outbreak in Bombay triggered major changes in public health policy. Governments began investing more heavily in sanitation, urban planning, and disease surveillance. Research institutions focused on developing vaccines and studying methods of transmission. One of the most notable figures in this effort was Waldemar Haffkine, a bacteriologist who developed an early plague vaccine and conducted large-scale vaccination campaigns in India. While India experienced some of the highest mortality during the pandemic, plague did not remain confined to Asia. Ships departing infected ports carried the disease to Africa, the Middle East, Europe, and the Americas. In many cases, the outbreaks occurred in coastal cities that served as commercial gateways. San Francisco became one of the first North American cities affected. In 1900, cases of plague were detected in the city's Chinatown district. Public health officials faced significant political pressure as they attempted to manage the situation. Some local leaders resisted acknowledging the presence of plague, fearing damage to the city's economy and reputation. At the same time, discriminatory policies targeted Chinese residents, illustrating how disease outbreaks could amplify existing social tensions. Despite these challenges, scientists and public health officials gradually pieced together the transmission cycle of plague. Researchers identified the crucial role played by fleas that lived on rats and other rodents. When infected rodents died, the fleas sought new hosts, sometimes biting humans and transmitting the bacterium. This understanding shifted the focus of public health efforts toward controlling rat populations and improving urban sanitation. Across the world, cities began implementing rat control programs, improved waste management, and stricter port inspections. Ships arriving from infected regions were carefully examined, and cargo was monitored to reduce the risk of rodents carrying the disease into new areas. These measures did not eliminate plague entirely, but they significantly reduced the frequency of large urban outbreaks. Throughout the early 20th century, the third plague pandemic continued to affect many regions, particularly in India and parts of China. Millions of people died during these decades. Exact figures remain difficult to determine due to incomplete historical records, but estimates suggest that India alone experienced more than 10 million deaths during the height of the pandemic. Beyond the immediate human toll, the pandemic reshaped global public health systems. Governments recognized that infectious diseases could travel quickly along international trade routes. As a result, international cooperation became increasingly important. Conferences and agreements between nations focused on standardizing quarantine procedures and improving communication about outbreaks. Scientific understanding of infectious disease also advanced rapidly during this period. The identification of bacteria as the cause of plague strengthened the broader acceptance of germ theory. Laboratories around the world began researching vaccines, treatments, and diagnostic methods. These developments influenced responses to many other diseases in the decades that followed. The pandemic also highlighted the complex relationship between environment, animals, and human health. Plague was not solely a human disease, it existed in natural reservoirs among wild rodent populations. Even when urban outbreaks declined, the bacterium continued circulating in wildlife across various regions. This ecological dimension meant that plague could reappear under certain conditions, particularly where human settlements overlapped with rodent habitats. By the mid-20th century, improvements in antibiotics and public health infrastructure further reduced the threat posed by plague. When cases appeared, they could often be treated effectively if diagnosed early. Surveillance systems allowed authorities to respond more quickly, preventing the kind of widespread urban epidemics that characterized earlier periods. Yet the historical legacy of the third plague pandemic remains significant. It marked the moment when modern bacteriology intersected with a global health crisis. Scientists identified the pathogen responsible, traced its transmission pathways and developed the foundations of modern disease control strategies. Public health institutions expanded their role in monitoring